Hi, I'm Dr. Bridget Abell, and I'm here to give you a very brief overview of the evaluation of the CALD COVID-19 Health Engagement Project, or CHEP. I'm a research fellow at the Australian Centre for Health Services Innovation at QUT, and we were independently engaged by the Refugee Health Network Queensland and their partners to provide an independent evaluation of the project, and that's what I'm going to guide you through over the next little while. So I'd just like to start by acknowledging the traditional owners of the land where I am recording this from today, the Turrbal and Yagara people, and pay respects to elders, laws, customs and creation spirits, and really recognise that these lands I am are places of teaching, research and learning. And also welcome any Aboriginal and Torres Strait Islander people who may be listening to this today, and acknowledge the traditional owners of the land wherever you might be. As some brief background, the CALD COVID-19 Health Engagement Project aimed to reciprocally engage and empower CALD communities and service providers for an effective response to COVID-19 pandemic by allowing access to appropriate services and resources, building health system capacity, and in turn, community resilience. At its core, it really was a partnership-driven initiative, and you can see some of the partnership members at the bottom of the slide. Essentially, the project looked like advice, coordination and connection between Queensland Health and CALD communities across Queensland. Really, essentially, the project was about amplifying the voice of communities in the development of strategies to overcome the barriers we knew they were facing in accessing health services and information during the pandemic. Now, as I said, the Australian Centre for Health Services Innovation was engaged by Refugee Health Network Queensland to independently evaluate the CHEP project for 2022. We had been involved in evaluation of a previous iteration of what CHEP looked like, which led to the creation actually of the current CHEP project. And really the evaluation was quite broad, wanting to understand the implementation, effectiveness and sustainability of CHEP during the COVID pandemic. And this was really across three different levels. Firstly, addressing health needs of CALD communities. Secondly, empowering and building capacity of CALD community leaders, organisations, community service, health providers and Queensland Health. And then finally, looking at how well it led an interagency and multi-sectorial partnership in terms of that approach to CALD community engagement. And finally, to assess the effectiveness, sustainability and transferability of this really important reciprocal engagement approach which underpinned the whole delivery of CHEP. Now, the evaluation methodology was quite broad-reaching, but this is just a snapshot of what was done. So we used a well-established evaluation and implementation framework, the RE-AIM framework, to structure the evaluation. But because of who we were working with and the rapid need for the evaluation, we really took a pragmatic and culturally appropriate approach, being very collaborative, using a combination of some existing data and some new data collected specifically for this project. You can see there was multiple sources, both qualitative, so narrative type data, and quantitative, which is our statistics and numbers, and then some which were a mixture of both. We used interviews, surveys, project documentation, social media analytics, really in terms of collecting data. And you can see that much data was actually collected by peer researchers or community leaders who were able to gather that data in the language of community members and then feed that back to OSHI and our researchers to perform all the analysis. So this was a very collaborative method of data collection and analysis. So those interviews and surveys were our stakeholder consultation of the evaluation, and we managed to speak to 27 different community leaders in interviews and discussion groups led by our peer researchers. You can see they came from a diverse range of backgrounds, including Africa, Middle East, Europe, Asia, and Oceania. Then we, in turn, interviewed another 113 community members from similar regions of the world and a range of diverse CALD backgrounds, as you can see there. So this really was a comprehensive evaluation. On top of this, we performed 29 interviews and focus groups with organisational level stakeholders from the health service community organisations, government and the project team, and they were conducted by myself as an independent researcher. So that's a very brief introduction to the methodology. You can find more out about that in the evaluation report, but just going to cover some of the high level take home messages from the findings, although there's many, many more in the report that you can have a look at. So first I want to share the findings about the reach, implementation and impact of information sharing through the CHEP project. And this was really important because it did show extensive reach of COVID-19 information into CALD communities, which is a key finding of the CHEP project. And why? Why was this so much more effective than our standard ways of sharing information? Well, firstly, it's that education was delivered in culturally appropriate ways. So information was given in plain English, which could then be translated into other languages, and then these in-language messages were shared with communities. A lot of education took place in community-based settings where communities felt comfortable and they could access them easily. And finally, these sort of education events included trusted health providers, so doctors, GPs, nurses, who came usually from a similar background to the people they were speaking to in their communities. And this was a really effective way of getting health messages and health information out to these communities. And so there was a resource called the Living with COVID-19 slide deck, which was produced by the project, which was highly effective, a very nice plain English resource that could be used at all of these education events, but also shared more broadly across communities. The second important thing about information sharing is resource development and dissemination. So what worked was having multiple formats. And this wasn't just text, it was audio versions, video versions, pictures, graphs, and really having this diverse range of resources was very effective. Videos particularly provide a really great way of increasing the reach of CHEP, particularly for communities with languages that might have lacked other translated resources. And in particular, videos like this one, personal stories about vaccination or messages to get vaccinated in language from CALD community and faith leaders were a very powerful and effective tool, particularly around vaccination. In fact, all of these videos that were made, there was 12 of them made for the project, accounted for 1/4 of all views on the project's YouTube channel. And then finally, the other sort of effective dissemination method was a bespoke WhatsApp group that was created for the project in partnership with community leaders, and being able to have that as a source of pushing out up-to-date and trustworthy information, which then was sent onwards to other leaders and other communities. So when we then asked community members where they got their information from, it was really heartening to see that the number one source of information about COVID was Queensland Health, was the Queensland Health website and Facebook. And I think that, shows and speaks volumes about the success of this project, because that wasn't the case in other states and jurisdictions during the pandemic. So really, there were high levels of trust and accessibility of information from government and health sources, and that was really wonderful. The often did use press conferences and news media to get COVID information, but usually these were Queensland Health press conferences, which is once again a great sign the project was reaching the audience. Interestingly, a lot of CALD community members sought information from their general practitioner. Although the project didn't explicitly engage as much with GPs, this is a potential source for the future to think about, and using GPs as our trusted messages for communication. And finally, there was much sharing through CALD community organisations and leaders and their pre-existing groups, which were also tapped into by the CHEP project. When we asked leaders how they shared information, you can see it does much align with these sources, but also you can see the diverse range of sources that they were able to share across, and why they're such a valuable resource. In light blue, the most commonly way they shared information was in person at community events and information sessions, or through social media groups, pre-existing WhatsApp or Facebook groups or Zoom. And so this just shows the importance of engaging leaders and the reach they can have across multiple sources, and why you also need to have different formats of information that works best for sharing by different means. So moving on to our next level of kind of project impact, and that's the community leaders, because this project really was about working with community leaders and empowering them to share information. And this is a really lovely quote from one of the community leaders to show the impact of the project, who said, "The project empowered us to then empower others." And really, there was a very strong ripple effect of information. So giving it to one community leader who then shared it with another community leader or their own communities who then shared it with their families. And it really was this lovely ripple effect of information sharing. But community leaders told us that they increased their knowledge and skills, and not just around COVID, but just around how to share health information with their communities. They built connections and trust with each other, but also with the government, with health providers, and particularly with the Chief Health Officer, Dr. Jeanette Young, who was highly praised for her engagement with CALD leaders. And really, it was a very effective approach in building trust and making CALD leaders feel valued, heard, and empowered. This is a great quote saying, "I felt empowered and listened to, especially those meetings with the health service executives. I felt appreciated, and I think it was a very good experience." So leaders, very often singled out the chief health officer and all of the other high-level stakeholders who took the time to have community forums with them and really listen to what was going on in their communities. On the flip side, though, we do need to be careful not to avoid overburdening leaders and really over relying on them to deliver messages to whole communities. They are one potential channel and a wonderful channel, but we need to make sure we're using diverse methods to engage with communities because, as this quote says, we forget that they're already dealing with all these other challenges in their community and then COVID on top of that. And so they do have a large workload that we need to make sure we take care of and nurture those community leaders. So the third level we like to think about in the evaluation is the partnership approach. So that's having all the different multi-sectoral agencies working together and working together with communities. And so this was a very highly effective approach for supporting COVID-19 messaging and meeting the needs of communities. And as I said, there was this really strong ripple effect, which amplified the reach of the project. And this was really, exemplified when we asked in a survey of all the different partners who were involved at varying levels with the project, how satisfied they were with participating in the partnership. And you can see there the average response was 92% out of 100%, almost all completely satisfied. There were some who felt less so, but that maybe had particular reasons for those responses. And when we asked them about the benefits of being in the partnership and asked them to say whether or not they'd experienced those, you can see that 100% of those surveyed said that being part of the project enabled them to address health messaging about COVID-19, enhance their ability to meet the needs of their communities, and allow them to contribute to their communities. And those really are the key goals of the CHEP project. So it's wonderful that those in the partnership felt those as benefits. But you can see lots of benefits of being a part of the CHEP project by all of the different partners. And, I guess the take-home message from that is that such an effective partnership was built that it really should be sustained. So keeping the structures live, but perhaps hibernated, and then they can be, ramped up and really brought back into practice when another crisis or another need arises. And so when we looked at what it was that made, I guess, CHEP both appropriate and effective, it could sort of be categorized into 6 key features, and these are depicted in this graphic here. And so I guess the key features are firstly that there was a specialized, dedicated core project engagement team who contained both partners from health and government and CALD community members and leaders. Secondly, that there was experienced cross-sector leadership embedded in a health service and within existing networks, the Mater Refugee Health Network. Thirdly, that there was a complementary and coordinated response from partners, invested partners. And then I guess this sits in existing trust and connections to and within community, and also within flexible ways of funding and working with each other and with communities. And then finally, a willingness of stakeholders to be led by community. And these things are, I guess, in the essence of what makes CHEP successful, and the combination of these things really drove the success of the project. So the last thing we wanted to look at was the transferability of this type of approach to engaging with communities. And this was really because CHEP resulted in a critical shift in power and trust toward communities to decide what was required and when and how they should be supported. And I think this mainly occurred because there was this ongoing feedback, co-design, and action loop that happened in collaboration with communities, and that things could be adapted and provided on an ongoing basis. And I think some of the key was to have holistic and culturally appropriate approaches to all engagement activities, really seeing what the community needs and meeting them where their needs are. And so this quote is great in terms of the community involvement. It's really putting the power in the community. They've got such a strong voice in this and they're really driving it. Putting the power in their hands is really important. So any sort of future engagement approach should really think about giving the power to the community and using them to guide what's being done on a higher level. There were some issues, I guess, with this approach in terms of COVID fatigue. This was a COVID project. However, it doesn't have to remain a COVID project. It was very clear from discussions with stakeholders that there is transferability and replicability of this approach beyond the pandemic. This was really just a case study of how this type of engagement can work and the impact it can have, and was probably hastened along by the pandemic. And it really, by many stakeholders, was now being called an exemplar of CALD community engagement. And really, this is the type of thing that we should invest in the future if we really want to engage CALD communities effectively. And so that's all I have time for today. As I said, it's a very high level overview, and there's many more detailed findings and recommendations in the evaluation report, which you can access from the Refugee Health Network Queensland site. And I would like to thank all of the evaluation partners, the CHEP team, the peer researchers, community leaders, and communities who contributed an enormous amount of data towards this evaluation. And if you would like any more information about the evaluation, please feel free to get in touch with me via email, phone, and I can more than happy to answer any questions. Thanks for your time today.